This is the start of really needing to develop biomarkers aside from just HER2. Yeah, I think the bispecifics are really cool, so, and then combination as well. We've done some preclinical studies at WashU where if you incorporate ADCs, TKIs with ADCs, you may allow for better internalization and perhaps better responses and durability. So I think combination regimens are going to be interesting. I think we really need to understand better what are resistance mechanisms to all the therapies so that we can, start to think about what are the new next generation of therapies that we need to bring forward, that are targeting HER2.
I would add to that, we do have some studies that are should read out soon with PI3 kinase inhibitors. We do have the oral SERD inhibitor. I think Persevera with giredestrant that are also behind that we would need to see what those readouts are and how it impacts what we do.
I think at ASCO we had data with gedatolisib. And so that's a PAM pathway inhibitor, and the data was quite impressive. Usually when you combine PI3K inhibitors with, or even mTOR, like the everolimus, the ancient everolimus trials with HER2 blockade, it can be quite toxic. So to have these less toxic therapies and available, I think, especially for tumors that are PIK3CA mutated, we've already commented that those tend to be more aggressive. So definitely exciting times.
So as we wind down, what is your main takeaway to the audience, but your collaborators and or referrers in regards to DB09 and the whole landscape of metastatic HER2 positive breast cancer?
So I will say that this is the first time in over a decade that we have seen a shift in the first-line setting. And I do believe that we are going to need to be more precise in terms of identifying biomarkers to really guide us in, what's the right treatment for the right patient. And so I do think that it's really exciting times because we have a lot of options, we have a lot of approaches, and we know that some patients can do very, very well with one approach, and others that have more aggressive, disease, they may require a different approach. And so this is really the time that we're going to have to use, those biomarkers and identify biomarkers. Even last year, there was some data looking at the HER2 DDX and high ERBB2 score. So in tissue specimens from Cleopatra. And if we see high score, then those patients had a more durable responses or longer PFS as compared to low. So I think it's really typically, we've started to use genomics to help determine, therapy options for ER positive, HER2 negative. I think this is the start of really needing to develop biomarkers aside from just HER2, the presence of HER2 amplification or positivity to really identify the best treatments.